Bienvenidos a todos y a todas a este segundo día de las jornadas de informática en salud del Hospital Italiano de Buenos Aires, o HIS Summit, como se llaman este año. Junto a Victoria Regia Lombardo vamos a estar moderando y coordinando este nuevo track de salud pública y gestión sanitaria. Y de ahora hasta las 5 de la tarde, con algunos breaks, entre medio, obviamente la hora del almuerzo y de un café que cada uno disfrutará en su casa, vamos a tener la posibilidad de escuchar a destacados oradores nacionales, internacionales, de contarnos sobre distintos proyectos de, obviamente, informática en salud, con un impacto o una ascendencia especial en la salud pública. Y para empezar, abriendo la sesión, vamos a tener a Enrique Martins, que es nuestro keynote, y que va a presentar su charla sobre XpanDH. Enrique es coordinador del proyecto XpanDH, una iniciativa de la Unión Europea sobre la que va a hablar en esta sesión. Es médico, profesor universitario en la Escuela de Medicina y además en 2 escuelas de negocio, donde enseña e investiga en salud digital, liderazgo y educación en gestión para estudiantes de medicina y otros profesionales de la salud. Ha sido presidente de la Agencia de Salud Digital de Portugal, liderando esfuerzos nacionales de e-salud durante casi 7 años, y copresidente del grupo de Estados miembros de la Red de Salud de la Unión Europea. También ha trabajado como Chief Medical Information Officer en el Hospital Fernando Fonseca de Portugal durante más de 4 años, liderando una rápida transformación digital con la implementación de un sistema de historia clínica avanzada y creando además un centro de investigación. Actualmente también trabaja como académico en 2 escuelas de negocio y en la Escuela de Medicina, como comentamos, pero además tiene proyectos de consultoría individual, además de su rol en este proyecto de la Unión Europea. Por esto, Enrique, te agradecemos muchísimo. Thank you very much for being here. Enrique is a native Portuguese speaker, so he speaks Portuñol or Portuguese, but we agreed on having his speech in English for this presentation. Thank you very much for being here.
Thank you very much. I was almost crying with all your reading of my CV, considering I'm getting old, perhaps. But anyway, maybe it's the timing. So thanks, and very happy to participate in this session. I will be actually addressing a public health audience later in November. We have the European Congress of Public Health. It's going to actually be in Lisbon. So if anyone of the audience is planning to come, I think that could be an interesting thing to do. It's on the 12th, 13th, 14th, and 15th of November. And on the 15th, we have a dedicated morning to digital and public health. So that's my invitation. Just drop me an email in case you're passing by Lisbon. And sorry, but I really think you benefit more from listening to me in English than in my humble attempt to speak Argentine language, not to call it Castellano. And that's a provocation. Anyway, I thought about, thinking through these 4 topics and really looking at them from the angle of public health. And in order to do that, I want to first open the floor to everyone to think what is in fact digital health. And it is no more than the use of digital technology to improve healthcare systems delivery and health care. So it's giving equitable, safe, efficient, patient-centered, timely, and effective healthcare to everyone. In a moment of the world where people are getting older, we have more and more technology, and we're supposed to be knowledgeable, more knowledgeable. Although, in this famous logic of data, information, knowledge, and meta-knowledge, I always like to remind everyone that knowledge is rare. It's a little bit like a stone, a jewelry, and that you put on the data, which is the new gold. And then meta-knowledge is knowing how to design the jewelry. So you may have the same gems, the same emeralds or the same diamonds, and have a lousy design or a good design. So what makes a jewelry is of course, good base of gold or any other metal, and then some gems, the knowledge, and then some meta-knowledge, which is the underlying design that you have created with that knowledge. This has a metaphor. In a public health audience, this has to do with what do you really, as public health professionals, take out of the data that has been accumulated in the last years in this ongoing digital transformation? And sometimes the answer is very little. I have to say that for me, it's very appalling, very sad that some of the public health procedures, counting cases and things like that, still run on a very, I wouldn't say paper-based, but very sort of old-fashioned way. As a way of provoking the audience, I always like to talk about the difference between populational health and public health. And, public health for me, I always remember, I'm an internist, by the way, so I'm not a public health doctor. And in sampling, why sampling when you can have the full data set, I always say. So in the case of Portugal, for example, we have a national database with all vaccines for all Portuguese from all times. So we don't need to sample and show that, well, there's a sample of people that are not covered by vaccine X or Y, and we can generalize to the population. We can go directly to the data of the population. And this is the truth for also all the prescriptions in our country, for example. So I invite you to think of populational health as something that has access to large amounts of data, and on precision public health as the concept of tailoring your public health interventions based on data and on AI, which is, of course, built based on data. But having the capacity to analyze the old classic analytics, but also having the capacity to personalize, to go down to the level of the person or even the family and say, okay, for this family, we do need to do this intervention because this family has a particularly higher risk of combining some genetic tendency with some environmental or micro-environmental exposure. So this is important as we move to new digital health systems. So everyone wants a new healthcare system that is preventive, is paperless, is empowering of the citizens, of the individuals. It is personalized, both at public health level, but at healthcare level in general. And it is accountable. When it fails, we know why it fails and where did it fail. And finally, that every one of us can be our own healthcare creators, as we also are our own cooks. Most of us cook the food we eat, right? Some of us do have someone to cook for us, but we're not all privileged people. Anyway, digital patients are the new reality. I want to invite you to think about that. And I don't have time to go into the details of that, but it's just to set the scene. And this means that technology is going into humans more and more. We started by interacting with portals, with apps. Now we have watches and bracelets. And soon some of our patients have devices like insulin pumps. You can take it out, but it is connected to you. There's software around it. There's a glucose meter that has information that goes into an AI model and determines how much insulin a diabetic type 1 will need. And then there's implantables like deep brain stimulation for Parkinson's disease or pacemakers with Wi-Fi. So these things are already there. And of course, in science and science fiction, we have micro-robotics, cognitive nanobots, so nanoscale robotic structures that can, for example, in theory, move around the brain and clear tau protein and other proteins related to dementia. And then, in the sort of science fiction movies, we have avatarization and artificial life. And what is health data? So when we talk about the European health data space, well, maybe it's not a bad idea to have a fairly good understanding what is health data. And that would take us an entire week, and we would still have a lot of doubts about it. But one thing we know, it comes in two big shapes, structured and unstructured. Typical structured data, medication-related data. It's quite well structured. Typical unstructured data, well, maybe a clinical note, maybe a video of how a patient moves. That is unstructured data and is not textual. Now, data can go from very classic, well-robust data for medication, demographics, or diagnosis, to social history, family history, lifestyle, and environmental. What streets did this patient walk through that triggered his asthma? Where was he in the city when, you know, this dust wave came and he got a lung reaction, bronchospasm? So what are, for example, in Portugal, we had a very interesting public health study looking at what parts of Lisbon are more dangerous when a heat wave comes, when we're talking about increased mortality for elderly patients. So we use the citizens database and the death mortality index and the certificates, digital death certificates, and we were able to find what were the neighborhoods where the likelihood of dying with the same age, same conditions is higher due to the heat. Maybe the houses are facing the sun, maybe they're not well isolated. What is public health data? If you're interested, there's a very interesting report. Well, I'm biased because I wrote it, but you might find it interesting. It's only focusing on European public health data strategy. This was a report in the year of COVID, and this was commissioned to me to write about how did Europe deal with health data in the first months of the COVID pandemic. So I went through the concepts and I came out with very simple, clear, for me, very clear data about communicable diseases, easy, everyone understands, classic type of data for public health, data on non-communicable diseases, data on health systems. Where do we have beds? Where do we have ventilators? Where do we have capacity? And finally, data with public health relevance. And this includes, for example, movement of people in a city, which when COVID came, became relevant for public health. So many data is not health data until something happens. And soon we realize that actually the way that person was driving the car, the way the car was systematically going to the right side and not the left, showed that he was having or she was having some sort of visual distorted field, maybe due to the installment of early stroke. So don't be too rigid on the concept of health data. Keep it fluid. European continent, the other day someone told, so Europe is good at exporting regulation. We don't export hardware anymore. We don't export software that much, but we do export regulation, and that's kind of true. So we've been doing a lot of regulatory effort, both in the AI world, health data space world, and health Data Governance Act and the Data Act. All of these European level legislations have the purposes of opening data silos and making data available for researchers, public health managers, this within the space of health, but also in other areas in other industries. So this proposal of a regulation for the European health data space was put forward in May 22. It has been voted in favor in April 24. For those of you that might not know the dwellings of the European Parliament and the European Commission and European Council, this is a record. Less than 2 years to approve an unheard of legislation about a very difficult topic, which is health data, was only possible because there was a strong political commitment. COVID came, and public health was clearly ill-prepared to use health data at a European scale. So European health data space is a health-specific ecosystem comprised of common standards and practices, infrastructures, and a governance framework. So it's not a data lake. It's not a bunch of bits and bytes on a server somewhere in the cloud. It is coming up with standards for data capturing and data transferring, its practices of, for example, data authorization, granting, and data requests, but also infrastructures, technical infrastructures, and governance, who asks who and who decides. Organized into two areas: primary use of data and secondary use of data. Primary use of data is the concept of when I'm seeing a patient, I'm writing on the electronic health record, that is primary use. When I pick data that was collected by others and I take out the names and take out any identifier, I then use this data to produce populational health statistics, analysis, analytics, and prediction models based on AI, for example. So there's a legislative arm, there's an issue on quality of data. So right now, one of our big focuses is the topic of the European Electronic Health Exchange format, because if the way the data is captured and transferred is not systematically done, it is not standards compliant, the data quality is not good, the decisions are not going to be good. And then, of course, there's infrastructure to be built. There's different projects contributing to the infrastructure, and a very important aspect, capacity building and digital skills. And on this next year, I was informed that you want me somewhere around this time of the year in Buenos Aires, so I'm hopeful that that will materialize. But my point is, by then, I will be coordinating another project called XIA, XIA, which is focusing on capacity building, teaching IT staff, teaching doctors, teaching nurses, teaching public health doctors about how to use these advanced standards to get better at collecting, using, reusing health data. Definitely access to health data for research and policy making, which in the scope of the European Commission includes public health. So for this community of people, there is no significant difference between health policy and public health. Now, we know it's different, and we know that the actors, health policy actors in a country, may be very different from the public health people. But one thing we know, if when they work together, they go much further. Now, and then finally, the concept of circular use of health data, a little bit more esoteric, but just to give you this idea. We collect data from our patients in our conversations with patients. That data can then be used in a pseudo-anonymized or anonymized manner to produce an algorithm that will be applied to my patient and highlight, suggest something for my next appointment. So maybe next time I see this patient, my electronic record will be pre-filled, will be already having some information there, or maybe it has two questions. Hey, don't forget to ask him this. It tends to show 1 year after that thing that you documented last year. And this is what I call circular use of health data. So it's when secondary use gives space to inferences that help the interaction again between clinicians and patients. What's the role of the patient is the digital health integrator. So more and more patients, at least in Europe, have the role to access, curate, accumulate their data. But I'm not going to go into this in detail. I want to seduce you to this idea that if it's fair to talk about the European health data space, 2 years ago, we wrote a small paper. It's online. If you Google it with these words, people-centric model to harness user value, you will find this paper of the personal health data space. And funny enough, this paper came out a few years before the regulation. The regulation has now Article 8, which kind of is all around this pyramid. Access to data, accumulation of my own data in a digital format, curation, editing, adding, deleting data, and control. If I want to donate my data to research or public health policy, then visualizing and analyzing, understanding my health through my health data, and finally using health data to take care of me, even in the backseat, like we do with Google Maps, advising us the best route based on other people's routes. Now, what is XpanDH? It's a simple project, small project, 2 years. We're now running close to the end. This year we finish. We are on the web and on LinkedIn, so you can follow us. I will show you the QR for the social media later on. And what is Expand all about with all these partners, and some of them speaking Spanish, as you've seen. And it's about supporting Europe in the usage of the European exchange format. So Europe has already started many years ago. I was behind some of these scenes, but that's another story. Connecting countries and sharing data across countries between Portugal, Spain, France, and so on. Throughout the years, this has been accumulating, and we now share what we call patient summary, a subset of relevant data about one patient, or e-prescription. So a normal prescription, but in this case, rather than go to a Portuguese pharmacy, the Portuguese happens to be in Finland, he will go to a Finnish pharmacy and pick up his medication. So these services already exist. So every day there are Europeans getting their prescriptions done in one country and picking their medication in another country. And regarding patient summaries, also there are access to patient summary by doctors, especially emergency room doctors, that want to know more about that patient, might speak a different language because we have 25 different languages within the European Union. And this is sort of the timeline. I mean, you can see the flags. Portugal was proudly ahead of time with both patient summary and e-prescription. I'm very proud of that, of course, but other countries are now joining, and that's what's more important. What is the European format? It is a set of requirements, technical specifications. It's very esoteric, what I'm saying. Right now, you're thinking, what the hell is this guy talking about? What does this matter for public health? Well, it matters because we will soon be defining under this structure, for example, a European template for a death certification. So right now, that certification is different across the countries. Can you imagine, even in the world, if all death certification had the same structure and the same data fields? Can you imagine that the power of the statistics we could get? It's incredible, right? So we just need to have a way to agree, and the format is a way of agreeing. We then need to agree on the exact details, but it is a way of thinking and a way of agreeing, which helps the different levels of access, accumulation, and empowerment through data that I had referred to you back then. How are we doing this? Well, we have received specifications from a previous project. We want to test them against people's opinions. We want to test them against experiments, as we call them, in the real world with different hospitals and different primary care units. We have the XNets, networks of different stakeholders. So we want to involve all stakeholders, so group them in these clusters that I call XNets. And then we also created a concept of co-creation where patients, programmers, and professionals, the 3 Ps, come together and also contribute to new use cases, new ideas for the format. And so this means that people can engage, and if you're interested to follow, I mean, do promote our social media and the project itself. Take time if you want to screenshot this QR code, or just go to Google and write XpanDH, and you'll find the product. The last 2 minutes, I want just to highlight 2 other final ideas. One is why and how for a global EHR. So there's no reason for not also thinking of all these topics at a global level. So I know that IHE, which is the non-for-profit organization that connects vendors, is going to do an event in Latin America, which they annually do, presume with some companies from Argentina, companies from elsewhere, where they're sort of testing how patient summary can be created and shared into the different countries in Latin America. This is supported by PAHO, the Pan American Health Organization, and it aims to explore the potential of what we call the international patient summary. So it's one step forward to the global EHR, as I call them. And what is a global EHR? Is a set of interconnected digital systems and services that support sharing of personal health data across the globe. Now, it might be connecting hospitals to hospitals, governments to governments, or just giving the patient access to his data on his mobile phone in a way that he can download it in the language of the country where he's landing. So I always give this example. If I have a patient summary, my phone knows I'm now in Korea, so he would present my patient summary to me in both Portuguese and Korean. If I happen to go to a hospital, I could slip and show the Korean version, trusted translation of my patient summary. So these are the types of services that we believe citizens could benefit. Maybe not all, but definitely those that do benefit, they benefit from something that didn't exist before you create this. It's always what I give as an example. Some people say, "Oh, but only 1% of the population flies around. So why do you need a global EHR?" Well, for that 1%, for that one out of 1,000, whatever. And then finally, it's about your mindware. So I know the audience is possibly a mix of programmers, professionals, and some of you are patients, I'm sure, like I am. What are you going to do to your mindware? Are you going to change? Are you going to format yourself for the next 30 years? Because change is coming. Healthcare is going to be powered by AI. Either we like it or we don't. And I was listening to the Charla discussion panel before me, and they were talking about virtual assistants. And of course, this is coming, and it has powerful implications also for public. To help us think through this, Europe also is relatively good at producing ethic frameworks. Ethics is useful for us to consider principles like leave no one behind. And for example, in the areas of digital health with humanistic values, very important is that individuals are informed about the benefits and limits of digital health. Individuals are informed about the functioning of digital health services. And when you use AI, all reasonable efforts should be made to make it explainable, what we call explainable AI, which is a very early, very ill-developed area of AI research, but definitely one that we at Europe depend and believe should be important to temper the impact of AI with the participation, the citizenship, and other principles that I'm not going to dwell. But this is online. This is available. Of course, my slides will be made available. If you want to read more of my ideas and papers, there's a list of them. Not all are there, but some of them. And then you can also listen to Spotify and Soundcast. So thank you very much. And I think I'll open the floor for questions and comments. I mean, do feel free for any comment and any question at any time. Now or later, you'll have my email as well.
That was awesome. Thank you, Enrique, very much. It's really, really interesting what you have achieved in the European Union. And maybe to start with the questions, and we will get five minutes for those. One question might be, even though this seems like patients' rights issue about exchanging health information for healthcare in terms of being on the same continent in Europe with all the people moving around, and we know that this is easier in a region like the EU. But what do you think would be the business case for industry to fit in this great framework of information exchange beyond, of course, the need for patient information, for patient healthcare that, of course, the patients are willing to?
That's a very interesting question. Very quick answer. The last time I came to Korea, not this one, on both ways, from Istanbul to Seoul and from Seoul to Istanbul, I was called as a doctor on the plane. The first one, it was an easy case. The patient had quickly gone to the toilet and the problem was solved. The second one, I had to administer the drug to a Korean lady that I couldn't understand was allergic to or not, the drug that I was administering to. Thank God she didn't have an allergic reaction. But, you know, I didn't know. And I could have known if all the people in the world have a patient summary, which includes allergies coded on SNOMED, and those SNOMED codes have been made available for free. You know, and all companies ask you, can you please upload your patient summary when you upload your passport picture? And I mean, no one tells me that is maybe more sensitive to upload your allergies than to upload your picture with all the details of your passport, which everyone does every time they want to fly. They take a photo of their passport in many airplane companies now these days. And now then I would ask the lady cabin attendant, could I access the patient summary of this patient just to check for allergies? Business case, maybe worldwide travel insurers might want to save money with paying things they shouldn't need to pay because reactions shouldn't need to happen. Maybe patients are willing to pay €1 or €1. I don't know. Forgot now. Doesn't matter, but you get the picture. I mean, maybe I'm willing to pay €1 to make my travel safer by uploading some of my health data and making it available to any doctor on board just in case I fell sick. And if I'm, 19 years old, I'm possibly willing to do this because I am afraid. Many citizens are now afraid of flying because they're getting old and chronically ill. But they have money. I mean, if you pay €1,500 to get to Argentina, I mean, you might as well pay €10 to get the health information to fly with you. So I think there's a lot of examples where with the right incentives. Now, let's get going. You're muted, Daniel, so I cannot hear you.
I think no one can. Thank you for that. But related to that, do you think there would be some pushbacks from any stakeholder or interested party in this information exchange?
There's many. I mean, I always say these two examples. For example, when people say, oh, integrating health information will reduce the number of repeated examinations. Anyone selling examinations will be not very happy with this. If you sell x-rays and now you sell 10% less x-rays because the national EHR saves 10% of unnecessary x-rays, it would be expectable that people selling x-rays will not be happy with you. The same goes for labs. I always say any IT system that reduces costs buys you a lot of ugly and bad people against you because they lose money. Now, if you can find a way to not lose money, but shift the money from ones to others and allow the industry to transition, in this case, to high-value imaging and not low-value X-ray copying, then they migrate to a value addition of imaging services that allow you, for example, to detect cancer earlier. In that case, everyone wins because the citizens will live happier lives, they will be more productive, and there will be more money for healthcare. You can even increase slightly the expenditure and thereby giving money to those people. Then they will be happy, then they will follow you.
Thank you, Enrique. And maybe the last question, and thank you, Esteban, also for being here already, and we will move forward with your talk after that. Is there any financial incentive for countries or for hospitals or different healthcare institutions to join this European health data space? You know, the simple rule of carrots and rods and sticks. So which would be the way or the path forward for the European health data space to be a reality in the next years?
So we have both. So we've been actually this December, it's the 20th 20 years of EU-funded projects on interoperability. So European money has been used to get people together, to conceptualize, to agree on standards, to build many of these ideas. And we have, in the last 5 years, started to have grants. I'm talking about 2, 3, 4 million grants for each country to adapt their own systems and start contributing. This is peanut money, because the total money you need to spend to prepare your infrastructure to produce, for example, one summary for each Portuguese, or for, and I know the cost, but for each German, it's much more than that. But it is a sort of a, it's a seed money that incentivizes governments. But yes, we had to go to the stick. This is why it's a regulation. It's compulsory. It doesn't need national legislation. For those of you that are not from the EU who might not know, a regulation goes into legal force even if the national parliaments do not endorse it. So it is direct law. And therefore, we are now combining both, a sort of some funding with so some carrot and some stick, as usual, is a good combination.
Okay, thank you very much. I think your presentation and your answers were very clear and really insightful, not only to learn about what's Europe doing, but also to try to move in a similar direction. And you mentioned that the Pan-American Health Organization with other organizations here in the region are trying to promote this kind of interoperability. But of course, the European Union as a common market and as a common place with these legal frameworks that you have mentioned, that let's say you can make something mandatory for all the countries in the region, is a kind of governance framework that we don't have and won't have in the next few years. It's something that it's really hard to build and would be a kind of dream to have it here. But at least we can move with baby steps and start with different alternatives as we are doing. And also within the countries, some countries like ours, like Argentina, that is a federal country, we have our own challenges also, because each province or each state, subnational state, has their own rules. And of course, we have to agree on many things, similar to what Europe do when dealing with all the countries. So thank you very much for that. And there's people interested in reaching out to you to learn more about this and to ask questions. So I think they would be pleased to get in touch.
Thank you so much for all the time and giving me the opportunity to be with you. Thank you.
Okay, Enrique, have a nice day. Thank you.
Thank you.